Good morning and welcome to the annual Breast Educational Conference sponsored by Sisters by Choice. I want to thank all of you for signing on this morning. The next discussion is about radiation and breast cancer. Radiation has been given for breast cancer since the late 19th century. And since that time, we have typically and traditionally given radiation over about 6 weeks. So investigators have looked at trying to shorten the course of radiation without compromising the outcome and quality of life. So there have been a number of studies evaluating comparing 5 or 6 weeks of radiation to 3 weeks, and in some cases, 1 week. And we're going to also talk about 1 day, for example, using intraoperative radiation. Because the goal of radiation, as most medical modalities, is to optimize the patient treatment. That is, we want patients to get the best possible outcome with the least possible side effects. So when we talk about radiation can be given in the curative setting. For example, when we irradiate prostate cancer or head and neck cancer, or in some cases, lung cancer. It is given for definitive purposes. But in breast cancer, it's usually given in the adjuvant setting, that is after your surgery, after a lumpectomy, or after a mastectomy. And it also can be given for palliative reasons to help alleviate the symptoms associated with the breast cancer. The standard conventional course of radiation is to be given over 6 weeks. And as you can imagine, that can create some logistical issues for some patients coming to a facility Monday through Fridays, 5 days a week for 6 weeks. So the goal is to try to expedite the radiation without compromising outcome or potential side effects. And we typically irradiate the whole breast, but we're going to also briefly talk about partial breast radiation. So we're trying to go from 6 weeks to 3 weeks, and in some cases, 1 week, but this is not a standard approach, but that duration is being looked at. And of course, 1 day with intraoperative radiation. Once again, the goal is to try to make radiation as convenient as possible, but as effective as possible. So let's talk about the 3-week course. There have been a number of trials, probably 5 or 6 randomized trials, looking at comparing 5 or 6 weeks of radiation with 3 weeks of radiation to determine the outcome and the cosmesis. One of the first trials is from the UK. It's called the START-A trial. It was a randomized trial comparing 6 weeks of radiation versus what we call hypofractionated radiation over 3 weeks. And with a median follow-up in that trial of just over 5 years, there was no significant difference in outcome. And also, the side effects profile was very similar in this trial. So this is one of the first trials to at least give the thought to many clinicians that we could probably give this over 3 weeks and have the same outcome and same side effect profile. A companion trial was the START-B trial, once again, 6 weeks randomized versus 3 weeks. And statistically, there was no difference in outcome. And in this trial, there appear to be lower adverse side effects with the 3-week regimen as opposed to the 6-week regimen. This trial was also from the UK. The next trial was from Canada, and they had the longest follow up. This was a randomized trial comparing 5 weeks of radiation versus 3 weeks. And at 10 years, the local relapse within the breast was about the same. There was no difference in outcome, and also the side effect profile was the same, 70 and 71% respectively. So, as a result of these three trials and some other trials, the organization which governs radiation oncology, the American Society of Radiation Oncology, ASTRO, published an executive summary stating hypofractionated radiation, that is, radiation given over 3 weeks, should be the preferred technique to deliver whole breast radiation for early cancer. So as a result of this publications, a number of clinicians have now converted from a 6-week course to a 3-week course. Remember, not every patient will qualify for a 3-week course. So it's really individualized to each patient. But I would say a majority of patients with early stage breast cancer should at least be considered for the 3-week course as opposed to the standard traditional 6-week course, barring there are no other contraindications. Well, to get a little bit more provocative, some investigators are now looking at 1 week as opposed to 3 week. And one of the first trials to look at this is called the FAST trial, once again from the UK, comparing 5 weeks to once a week radiation for 5 treatments, but given fairly elevated doses. And at least in this trial, at 10 years, there was no difference in adverse outcome, and the overall outcome was similar with 1.3 to 1.5% rate of recurrence in both groups at 10 years. This was another trial from the UK. It compared 3 weeks of radiation versus 1 week of radiation to the whole breast. 1 week, so 3 weeks versus 1 week, and at least the preliminary results showed that there was no difference in overall outcome or normal tissue toxicity. Keep in mind that these 1 week regimens have not been integrated in any standard recommendations for radiation. But it is something that a number of investigators are looking at, and this will take some longer follow-up to see if this will certainly play out in terms of how we treat patients with radiation. Now, we've talked about accelerating radiation over a shorter course to the whole breast. Some time ago, it was noted that most of the recurrence within the breast will recur in what we call the index quadrant, will recur in the area of the epicenter. So the question was asked, why do we need to irradiate the whole breast? Why don't we irradiate the site at highest risk so we can mitigate some of the potential side effects of irradiating the whole breast? So when we look at the whole breast radiation, this is an example where we are irradiating the whole breast, and as you can see, the whole breast is being irradiated, but some of the surrounding structures could potentially also be irradiated. If we can confine the radiation to what we call the tumor bed and a perimeter around the tumor bed, you do not have to irradiate the entire breast, thus potentially limiting some of the side effects associated with radiation. But you must be careful in your selection and select the right patient who may be good candidates for partial breast. And partial breast could be given with an external beam machine, or it could be given with what we call a catheter insertion. And there are a number of commercial products on the market where you actually insert the catheter the day of the surgery, and you give the target to the tumor bed with a margin around the target. Once again, you have to select the right patient to make certain that they're good candidates for this specific procedure. So partial breast was developed as an alternative to potentially improve access to breast conserving therapy by lessening the burden and duration of external beam radiation and irradiating the site at highest risk for recurrence, as opposed to irradiating the entire breast. This is one of the longest trials sponsored by the National Surgical Adjuvant Breast Project in conjunction with the Radiotherapy Oncology Group. And this was a randomized trial, but in this trial, partial breast was given in a variety of ways. So there's no one way in which they gave partial breast. Some patients received catheter insertions. Some patients received what we call interstitial implant. And about 2/3 of the patients, they were given external beams for their partial breast. But nonetheless, it was a randomized trial, and it was 5 weeks of radiation versus 1 week twice a day for 10 fractions. And in that trial, the recurrence rate was 4.6% in the partial breast and 3.9% in the whole breast, for a difference of 0.7%, but they did not think that was a significant difference. And also the cosmetic outcome were reportedly similar in this cohort of patients. The other trial that looked at partial breast used just external beam called intensity modulated radiation, the Florence trial from Italy that was published in the fall of 2020. And in that trial, they gave 5 weeks of radiation versus what they called 10 days of radiation, but the radiation was given in elevated doses every other day. And at 10 years, the recurrence rate was 3.7% in the whole breast and 2.5% in the partial breast, and they called this a non-inferiority result. That is, it was no significant difference. Cosmetic outcome was similar. This trial was from the UK. It's called the IMPORT trial. And they actually compared 3 weeks of whole breast to 3 weeks of partial breast. And at 5 years, the recurrence rate in the whole breast group was 1.1%, and in the partial breast group, it was 0.5%, but there was no significant difference statistically. Equivalent or fewer late adverse effect was noted, at least by this group, in the partial breast group. So we've gone from 6 weeks to 3 weeks, and the 2 trials showing 1 week. And so how about 1 day? And this is where intraoperative radiotherapy comes in, or IORT, where you're actually getting your lumpectomy and radiation during the same procedure in 1 day. The importance of delivering this type of radiation is selection, selection, selection. And you'll see that as we go through the 2 or 3 trials looking at IORT. In an intraoperative, this is just a diagram showing that the patient underwent a lumpectomy, create a cavity. This device is brought into the operating room and inserted by the surgeon in conjunction with the radiation oncologist, and radiation is delivered in the operating room. It may take an additional 30 to 45 minutes to do the procedure, but everything is done in one setting. The trial that many of us discuss is what we call the Target A trial from, once again, the UK. Just over 2,200 patients, whole breast versus single dose. 5-year recurrence was 2.11% in the intraoperative arm and 0.95% for a difference of 1.16%, but it was not significant, or it was what we call a non-inferiority results confirmed according to the investigators of this trial. The other trial was the Elliott trial from Europe, but they use a different technique, and the selection criteria was different, as you will clearly see from this trial. This trial had a median follow-up of over 12 years, but there was a 7% local recurrence in the intraoperative arm or the partial breast arm, and 2% in the whole breast. And the 15-year actuarial rate of recurrence was over 15% in the intraoperative arm or partial breast arm, and 2.4% in the whole breast. This trial has some different criteria, the different technique. The selection criteria was different than the Target A trial, but it did show a higher rate of local relapse if you don't choose your patient carefully and selectively in this trial. The US published its trial called the Target R retrospective trial with 5-year results. It was a multi-institutional retrospective registry, just over 600 patients. And overall recurrence was 6.6% at 5 years. It was 8% in the primary intraoperative group, that is, patients who just got intraoperative radiation, but it was fairly low, 1.7% in those who got unintended boosts. That is to say, they did get intraoperative radiation, and because of some adverse pathological features, that was followed by whole breast, and those patients had the lowest rate of recurrence. Interesting, in this trial, there were no recurrence in the delayed or intended boost group. So the delayed group of those who underwent lumpectomy, they evaluated the final path, and at some point they went a second procedure to insert the device. And some patients were designed to get a boost, and in these cohorts of patients, there were no recurrences. And the other issue to note is that patients who were compliant with their estrogen therapy, if their tumors were estrogen and or progesterone positive, had a 3.9% of ipsilateral breast tumor recurrence if they were compliant with the tamoxifen, or what we call an aromatase inhibitor. So the conclusion: about 70% of breast cancer patients will require some form of radiation during the course of their process. And typically that radiation was given over 6 weeks. However, more recently, a number of studies have confirmed that a shortened course of radiation is just as effective in terms of outcome and also cosmesis or cosmetic effect. In appropriately selected patients, and I highlighted this and underlined it, partial breast irradiation may be a good approach without any difference in outcome or adverse effect. Want to emphasize appropriately selected patients. But in short, we're trying to condense the radiation to make it much more convenient, much more effective, so patients can get the optimal treatment without any compromise in their overall outcome, and certainly do not increase any adverse event. But that's the end of my discussion, and I will be more than happy to answer questions at the end of this section. Thanks, and enjoy the rest of the program.